we go. That's cool with me. So yeah, why school mental health? I want to start with a little bit. I shared our teammates that are in the room. Thriving Minds is this partnership that we have created between the Rennie Center, between the Bright program, and between Massachusetts School Mental Health Consortium. And we are trying to help districts to build comprehensive school mental health systems, which is a tiered system of social, emotional, and mental health services and supports that leverages school-based staff, that is sensitive to community partnerships, that is ultimately using evidence-based practices and doing stuff like universal screening and group therapy and implementing more intensive services like Bridge programs, Bright programs, all kinds of good stuff. Social emotional learning is part of that. We don't want to fail to leverage the entire continuum. I don't know that I'm seeing some new faces, so I feel comfortable saying, like, I've said this an awful lot, but this might be new. We don't want to create different camps, the SEL camp, the behavioral health camp, the mental health camp. It's all the same thing, all right? Good SEL serves as a prevention activity for the onset of mental health problems. Give kids the knowledge, skills, and attitudes they need such that they don't need help down the line. Wonderful prevention, but it's in the same continuum. It's not the same as therapy, but it is a precursor to and prevention for the onset of mental health problems. So I want to reduce that siloing because I don't think it helps us at all. I'm going to talk about staff in schools today with an eye for reducing that siloing as well. I am going to pre-correct, or not pre-correct, but how about this? I want to ask that you don't kill the messenger here, okay? I am going to share some things that I think will probably challenge some perspectives that you have and have maybe held for a long time, or maybe haven't even really questioned, just things that have gone unchecked for a long time. And I want to challenge that, and I want this to be a space where we can have a discussion about some hard questions about the people that we leverage to engage in this work. So just putting that out there to begin with, in the event that this challenges you. But I don't think that you want to come to a session and not be challenged in your thinking. I would hope that we're coming to the session with an open mind and trying to ultimately come to a place where we learn something and we grow as a function of it. So I hope that you get something out of today that's like that. So I want to start with this. If you know the answer to this because you've seen this statistic, I would ask that you do not answer. But for those of you that don't know the answer already, according to the National Institute of Mental Health, how long does it take on average for an individual to secure mental health services from the point at which they start to experience symptoms of a mental health problem? How long does it take on average nationally? Please come off mute for $1,000 that Ellie has for you, or type in the chat, whatever you want. How long?
16 to 18 months.
That is incredibly specific, Bernard. I love that. Well played. 16 to 18 months. Lauren, who is not Pollyanna, offers 8 years. Monica says 1 year. Elizabeth says 1 year. Madeline, 2 years. Thank you for your engagement. 9 months. Okay. Anyone else? 1 year. Okay. 6 months. Okay, fair. I'm seeing between 6 months to a year. By a show of hands, who would agree with 6 months to a year? Quick show of hands, or a yes in the chat. Okay, I'm seeing some people. Who thinks that that ultimately our friend Lauren Suarez is ridiculous in saying 8 years? I don't. She's correct. 8 to 10 years is the national average wait time for an individual to get services after the onset of a mental health problem. What do you think about that? I'd love to get some reactions to that for people that put 6 months down. What do you think? I have legendary wait time. I see in the chat, I literally said what out loud, says Monica. That's great. Love that. Gina, people are not ready to get help. Took my daughter 6 years. Thank you for sharing that, Gina. Is it because they do not seek services right away? I don't know. That's maybe one of the reasons. That's a good call out. I think it's probably even more now post-COVID. Is that lack of access or lack of identification or right? Like all these things. It's making me think all these things. We keep going in the chat. Stigma. Good call, Lauren. Many years spent before seeking help. Insurance, stigma, fear. Gina offers, she didn't admit she needed help. Okay, co-pays. Friends, ultimately, I'm gonna offer one reason why, or a couple reasons why this is probably the case. I think Lauren, you offered stigma for sure. We do not have parity between physical and mental health. We stigmatize mental health. We make it taboo. It's a problem. We got to work on that. From a very practical standpoint for individuals that work in schools, I'm going to say that one of the reasons why this is true is because we are incredibly reactive as a mental health system. We wait for two things. What are the two things we wait for typically before we enact services, before we get kids help? Two things. What's one of them? There we go. Crisis, suicidal ideation. Yep. So you got one of them, crisis. The other one's diagnosis. Those are the two things that we wait for. That is not a great public health model, friends. We wait for things to get so bad that we have to enact care. Schools serve as the prevention arm of the mental health system writ large. No one else is coming to the table to provide proactive and preventative services and to engage in early identification through practices like universal mental health screening. There is no other agency or institution in the land that is better positioned to provide students an opportunity to engage in screening. I know that pediatric care is a place where screening happens sometimes. I also know that does not always lead to an uptake in services. I also know that the data is sometimes not looked at, unfortunately. I also know that it's not a universal capture because we know that plenty of kids don't have well visits, and that's a problem. So schools are uniquely positioned to engage in that practice, and it makes it such that the onus is on us to adopt these practices. I wanna just check for understanding, how is this resonating with people? What do you think, hearing all this? Let's be engaged. I know it's 3:45, but you're here. I think you're so right, and we need to get this message out there. Monica's like my favorite person in the room. She told me I was right. Thanks, Monica. Lauren says, I agreed. Lauren, I work at a high school and I know many students who are seeking counseling for the first time. Yeah, fair. What would happen if maybe those kids who are getting services for the first time in high school, what if they were identified 5 years earlier? Because that's possible, right? We could have done that. We could have enacted some process by which we identify them earlier. I'm glad they're getting services now, but imagine waiting 5 years with a broken arm. Imagine waiting 5 years for some kind of immunocompromised disease. Not cool. So ultimately, we have to be able to respond to these things in a preventative, proactive way. I wish mental health support was more universalized, says Clara, more naturalized, and also more resourced. We're with you there. I think everyone can agree to that. Okay, so I want you to remember this as we get into the arguments for why This needs to be a thing that we focus on, okay? And if you have questions as we go, please ask them. When we talk about prevalence of mental illness, this is outdated at this point. Gabby offers in the chat, sometimes family systems are the source of anxiety and kids don't feel comfortable asking the source of their anxiety for help. Well played, Gabby. Yeah, 100%. It means that the work that we do with kids is not enough. It means we have to actually work with the community. We have to understand how our families perceive mental health and communicate the importance of mental health in culturally responsive ways that are going to resonate with our families too. So good call, Gabby. Yeah, this is super outdated. Prevalence of mental illness, 20%, no way. We're looking at prevalence rates in the 30s and 40s, friends. No good. But let's just use these data because they're valid and reliable. Pre-pandemic, 20% of students will experience a mental health problem, mild impairment, 10% of severe impairment. This quote, I think, says an awful lot, and I'd ask you to put this in your back pocket for the stakeholders that you work with. Half of all lifetime cases begin by age 14. 3/4 by 24. Chronic disease of the young. Left unchecked, what happens? It doesn't get better. We're talking about problems that outstrip childhood and enter into adulthood, and that ultimately cause problems like that impact the workforce, that impact medical service delivery, that impact substance abuse, incarceration, educational attainment, all these things. We've seen that depression is impacting students at an increasing rate, for sure right now, yet about half don't receive treatment. There's a phenomenal study that Dr. Deepa Sakar released over the past few months out of Penn State. She's a wonderful researcher and supported some districts in getting mental health screening off the ground for depression at some high schools in Pennsylvania. And by engaging in the practice of universal mental health screening for depression, students were 6 times more likely to be identified and 2 times more likely to complete treatment. It's a practice that needs to happen. These are some data that I want to share to continue to paint a picture of need. These are data that we collected last year in Methuen. We engaged in universal mental health screening, K-12, with a lot of different measures. 37.7% of students at the high school had moderate to severe post-traumatic stress last year. About 34% of students scored in the moderate to severe range on a measure of depression, and about the same for anxiety. The data that isn't on there that I want to share is that 17% of students actually scored in the severe range across the board for all 3 measures: post-traumatic stress, depression, anxiety. It's not a good situation right now. This wasn't something that we could ignore pre-pandemic. We for sure cannot ignore it now. The good news is, and I want you to take a second to kind of orient to this graph. These are the 7-year anxiety prevalence rates for Methuen High School since we started screening. What you'll see is pre-pandemic a trend downward for severe and moderate and mild actually, and a trend upward for no concern. We saw an 8.5% increase, or decrease in moderate to severe symptom presentation for anxiety. I will take that all day long. 11.5% increase in no concern. These are numbers that run counter to national statistics. It's not supposed to happen. Why did it happen? Proactive preventative identification and services. That's why we're catching kids 5, 6, 7 years before they would have been captured otherwise. We're identifying them years before they would be identified without screening. Does that make sense to people? Thumbs up, you with me? Okay. Good. You can see what happened when the pandemic hit. severe spiked, moderate spiked, no concern dropped off the map. What happened over the past 2 years as we doubled down on the things that we were doing pre-pandemic? We're starting to see that it's trending in the right direction again. It's going to take time. Similar trending for the depression screening, severe and moderate going down, no concern going up. Pandemic hits, but now we're trending in the right direction again. We only started screening for trauma last year. So this is movement in the right direction, but it's only a two-year rate. So it remains to be seen if we trend in the positive direction still. In the chat, oh, Monica, very telling data, thank you. Joelle, a problem is we have to be prepared to provide support services for students who are identified by universal screeners. There are not enough pediatric mental health services available in schools or in many communities, especially rural ones like mine. Good call, Joelle. We're going to talk, and this is part of the piece where I'm going to say, don't shoot the messenger. We're going to talk about those individuals that are already embedded within your schools and what they are capable of doing. So it's not a perfect solution, but I'm going to argue that we are not effectively leveraging all of the individuals who could provide care to kids right now. What do we use to screen for trauma? Clara, we use the UCLA Brief COVID-19 trauma screen, which is, I can't wait for the COVID-19 life event checklist to be outdated and no longer relevant. That will be wonderful. When that happens, we'll shift to the more general trauma life event checklist. So it's a two-part screen: life events and the actual symptom presentation, because absent of one or the other, you don't get a complete picture of the impact of trauma, which is why, and this is really critical for those interested in trauma screening, why the ACEs screening tool, it's for adults and it looks at life event only. It doesn't look at impact, which makes it really less useful as a screening tool. Important to understand the aggregate impact of, or not impact, but the aggregate number of potential trauma events. But absent of an impact score, it's really not something that is going to be super useful to understand this kid needs help over this kid, because Bernard might have 5 ACEs and Clara might have 2, but Clara's presentation of post-traumatic stress might be off the charts and Bernard might have some protective factors in place such that that's not the case. Does that make sense to people? I know this is not a trauma screening presentation, but like I wanted to just throw that out there. Okay. There we go. So some more arguments for like why this is important. This is what happens when we don't provide mental health services to kids. We see academic performance drop off the map. We have more crisis. We have decreased attendance, behavioral concerns that potentially lead to suspension, which does nothing to change their behavior, but does set us up such that we are more likely to suspend the kid in the future. We have more substance use, increased rate of incarceration, healthcare costs, decreased productivity. No one wants any of these things. I get it. But this is what happens when we don't provide the mental health services and supports that kids need. Ultimately, when I look at this, I look at mental health as the magic bullet that ultimately mediates all these wonderful outcomes that we care about. If we do a really good job providing mental health services to kids, we are investing in academic performance. We are investing in decreasing substance use. We're investing in an increase in attendance. All these things get better as a function of improved mental health. So when you're talking to your stakeholders and when they're asking why school mental health, well, this is why. Because all the stuff that you care about is mediated by mental health. It's also the case that when we look at students that score in the high or very high range on a measure like the Strengths and Difficulties questionnaire, the GPA is about 13% lower on average for the sample that we were looking at. And students were also 45% absent 45% more often. So I know it's tough sometimes because we care about things that we measure. And in schools right now, we do not measure things related to mental health for the purposes of state reporting. It's just true. We have, and with humility, I love the screening program in Methuen. I'd put it up against any in the country. But the reality is that for our accountability report, I get a high 5. I don't get like an extra point on our accountability report. So it's the case that it's really important that we connect mental health outcomes to the outcomes that we are responsible for relative to accountability. Does that make sense? Okay. Just want to make sure to point out that and we should, I'm hoping we move in that direction. I want to be held accountable for our mental health outcomes. I think it's important, but right now we have to tie those outcomes to something else that is actually measured. Yeah, just some more connections to academic outcomes. Okay, let's keep going. So I've given you some justification around the rate at which mental health is a problem, the reasons or what it impacts ultimately, how it impacts school performance and lots of other outcomes that we care about. I want to hit pause real quick. What questions do you have right now based on what you've seen so far and what we've talked about? And if you don't have a question, what's one thing that you would say you're thinking about as a function of all this?
I could, if I could add something.
Elizabeth, you're on. We can't hear you, but we want to hear you for sure.
I can hear you. Can hear her. Can you not hear her?
If you want to mess with your audio settings and pop back in, I definitely want to hear your statement.
I could put a
Anyone
comment.
else?
I'll add to chat.
Can you hear me? Yeah, I could hear Elizabeth, but I don't know.
Yeah, I think John is having issues.
Okay. I'm thinking about the best place to start. I'd like.
Can you all hear me?
No, we hear
can
you.
Me. I can't hear you. Oh, my headphones were unplugged. There we go. That's what happens when you've got the little like the silly like, oh cool, like, we'll reduce the cord size and we'll call them athletic headphones. Not cool. Elizabeth, I'm so sorry. What do you got? Elizabeth is typing away. Clancy, did you have something?
Yeah, I'm thinking a lot about where to start, like how to start some of these things kind of ground up, because that's the situation in my building, is that there really wasn't a great structure for mental health or SEL, and now the pandemic just kind of enhanced all of what wasn't there effectively. So that's where my mind is going at the moment.
Totally fair. I think that generating that buy-in is so essential. I'm going to say I'm going to argue that probably a little bit easier to generate that buy-in now that things are like on fire, unfortunately, but we can't let go of that argument. We got to call attention to it and double down on it. Thanks for sharing that. Elizabeth, thank you for offering in the chat. Question or concern that I see K2, a lot of students are diagnosed with ADHD or the diagnosis of the day. Might that be part of the problem, missing the mark? Yeah, I think, Elizabeth, when we don't know what to call something, we maybe revert to what's comfortable, safe, something that we've heard before. And I know that, ADHD is something that is real. We have to call that out. But it's also the case that trauma tends to look like ADHD and depression and anxiety. So I don't know, important to rule out trauma. Also important to rule out that, you know, for some of our kids, anxiety and depression is resulting in behaviors that maybe look like off-task behavior. So in the absence of a good initial assessment where we're ruling in and ruling out concerns, we might be treating the symptoms and not the underlying cause. Like, here's the classic example. We've got an elementary level student that's exhibiting some behaviors, and we immediately put a behavior plan in place because we think that that's going to squash whatever's going on. But what we're not asking is that behavior a function of an underlying mental health problem? Because it certainly could be. And are we maybe putting a behavior plan in place that will do nothing to address the anxiety and depression? Gosh, I don't know. I'd rather be safe and rule it out first. Gina, I agree that too many children are being misdiagnosed. Or how about this, Gina? Misdiagnosed, not diagnosed. We wait for diagnosis. We don't look for symptoms. We look for a piece of paper that says a kid has a diagnosis before we intervene. Problems, all of them. Lauren offers, I'm thinking, if I can't get buy-in school-wide or district-wide, what is something that could still be considered in my circle of influence? Lauren, what's your role? I'd love to hear what your role is. You're a school adjustment counselor. Lauren, I will offer this. In your sphere of influence, you can enact really good evidence-based practice on a daily basis. You can engage in things like measurement-based care practices. You can measure the impact of your services. You can engage in small-scale identification of kids by getting consent from families to engage in screening. You can set up awesome group therapy situations. You can do an awful lot, Lauren, for the kids assigned to you. You don't have to wait for the system to change around you. You can change the system. What's the line from The Departed that, like, I probably shouldn't quote because, like, but it's like, I don't want to be a product of my environment. I want my environment to be a product of me. Like, be Frank Costello, please, in this situation and change the environment around you, but not in a dangerous and violent way like you did. So yes. And then we say, in reference to mental health school. All right, great. I think we're up to date on chat. So we good to move on? Okay, let's keep going. This is what we're gunning for, ultimately. This is the thing that we're trying to establish, a comprehensive school mental health system. It's that tiered system of mental health services and supports. I'm pretty sure I have a triangle next. Don't worry. But what this system does is it accounts for all kids' needs. So we're talking about social emotional learning and mental health literacy. That's for all by all. That's tier 1. And then we've got some other services I'll reference on the next slide. All of the things that we do within a comprehensive school mental health system, they're evidence-based. They have to be, because we don't want to do things that don't work. We are sensitive to collaborative partnerships, which should be. Community-based mental health is wonderful, part of the solution, not the solution. And that's the thing that I think we need to dismantle. Because if we're not pulling our weight, then we're never going to get to prevalence rates in the 30s and 40s. When you look at this definition, give me a yes or no in the chat. Currently, my district has a comprehensive school mental health system. Okay. We're not there yet. That's okay. That's okay. I want to say this. You don't get to it overnight, but you can start toward it. Elizabeth's point, working towards this, slow but steady. I love it. It's not the case that you can just change things overnight. But I also want to say that, you know what? Lauren is going to leave here and change things a little bit for her practice, maybe. Elizabeth's going to do some work to continue forward with establishing a system that looks like this, but this is the end point that we want to get to. And I lied, I don't have a triangle. I'll tell you right now, folks, if I didn't put a triangle in this presentation, I am breaking a streak like none other. I don't think it's going to happen. but we'll see. So I would love to have a little bit of engagement here. This means that we're coming on video if we can. I would really appreciate that. It would be lovely. It means that we're coming off mute if we can. That would also be lovely. Hearing some of what we talked about already and also drawing upon your expertise and knowledge, how would you communicate the importance of school mental health to families and students who are unfamiliar with this, and I should have said system? How would you justify the importance of school mental health? What do we think? We're all friends in here. No wrong answers. Come off mute. Come on.
I don't think that there's I don't think the community is fighting us with the need. I think that if we say that we're changing the system, sometimes we get a little bit of pushback saying, well, the school doesn't want to do what's necessary for my kids, or you're trying not to provide therapy, or you're trying to reduce the amount of therapy within school by handling it in a different way. So I feel that people will agree, especially because after the pandemic, that there's a heightened need for mental health services in school.
I appreciate that. Great answer. Got a couple answers in the chat. Collect data and share summaries. So Monica knows what's up. You've got some data already that you can share, even if you don't engage in universal screening. Who here does the youth risk behavior survey? Quick show of hands. Yep. Those are some pretty compelling data. I know there's a Metro West survey that goes out for some districts. Maybe familiar with that. You also have vocal data. Who here knows what vocal data is? BJ, you might be the only one, buddy. Vocal data is embedded within the MCAS survey that is conducted for grades 3, maybe 5, 8, and 9 or 10. No, 5, 8, and 10. I might be messing that up. But ultimately, it's a school climate survey that you've already done, but most people are like, we didn't do the vocal survey. And then I'm like, no, you just don't know that the data already hit your DESE Dropbox. You need the planning and administration, or no, planning and research. BJ, help me out here. You might know. Planning and research tab in the DESE security portal to be able to access the vocal data. So if you don't have that, talk to your system admin and they can hook you up with the permissions. But that's data that you already have to justify these needs. Cool. Elizabeth, author.
John, I just was going to say real quick, it's interesting because I was thinking about what folks were saying, and I feel like if I experience any pushback from folks, it's interesting because it's to several folks' point, it's not so much a sort of like kids' mental health isn't important. It's some version of like schools can't be the place to be all things to all people and all families. And, really our job is to support the kids academically, and it needs to be somebody else's job, and I recognize that maybe there's an impact, but, we can't take that on. That's where I feel like the energy, the pushback energy comes. So, and I don't know if other folks have encountered that or, have like kind of found ways to make the case, with folks who are in that space.
Such an important message, Paul. Anyone, does that resonate with others, what Paul just shared?
That sounded like a building administrator to me. There's some pushback, especially with those that don't have a special education background, that'll say those exact words.
Yeah.
I definitely hear that from some families, and I feel like I try to communicate scaling it back, that mental health is a lot of different things. And but yeah, I find that, some parents are definitely focused on all of school should be academic achievement. And why are you taking any time out of class that should be directed towards whatever, academic progress is there. And it's kind of scaling it back to kind of normalize. I literally had this conversation 2 days ago to normalize for your student to function in this academic class. They actually need support in this area, just like as if you bought them a pair of glasses. And it doesn't mean we're going into all of their family history, but we're directly looking at the dynamics impacting what they do in the building. And if I can differentiate types of mental health therapy and treatment, I get a little more buy-in from parents.
Love that. Really appreciate that comment.
Yep.
I like the differentiation of treatment piece that you offered, Clancy, too, because I think for a lot of times people don't actually understand what treatment looks like, and they've got this version of it in their head that is really outdated and unfortunately doesn't lend itself to an argument that it fits in school. So I appreciate that. Anyone else? Thank you for that, Paul. Really, really important call out.
Yeah, I mean, for what it's worth, I guess like at an even more basic level, it's sort of, sometimes I think a little bit of the response is kids spend more time in school than anywhere else other than their homes. And if we're going to, in fact, be able to have a chance to help kids be more present to learn, it feels like school is just a critical place for trying to do that work. And yep, resources are challenging, and yep, math class is really important, and you know, but I think it's a sort of an extension of what Clancy was saying. If we're going to be able to help kids who aren't currently able to learn to be able to learn as a, you know, come in association with a mental health challenge, there's really nowhere else to do it besides schools for a lot of kids. Something like that. Yeah.
Really appreciate that. 100%. If we don't get them the services and the supports they need, academics don't happen. It's not the other way around, right? You can't force the academics first and then get the kid help. Like, have to go in the right order. So,
I think too, I don't know, can you hear me?
yes. Awesome.
I think too, that sort of differentiating, but also connecting the concepts of, you know, therapeutic versus educational. And whereas I work with younger children, a lot of what we do is educational, and it's, you know, helping kids label their feelings, things that just give them some core knowledge. We teach mindfulness exercises. We do use literature to sort of highlight how characters respond to conflict and strategize, blah, blah, blah. And so it has a very educational focus, and then sharing that with teachers so that they can bring that into their classrooms comfortably and not feel like they're doing therapy per se. So just, you know, throwing that out there.
It's a good point, you know, because I think that perhaps some of our staff are worried about that, and lowering the temperature a little bit too with calling out some of the techniques that they use that are already like CBT techniques. Like, have you ever heard a teacher say to a kid, why don't you try the first two problems on the test and then see how it goes and then report back to me, and we can kind of go from there. We'll see if that works. And the kid goes back, all right, fine, like I'll go do the two questions. And they come back, yeah, all right, I did it. All right, great, keep going. That's just a behavior experiment. Like, that's a CBT technique, and we don't call it that, but that's what it is. And teachers use these techniques all the time. I'm going to argue that there's no more appropriate place to drop cognitive behavioral therapy than a school where every blessed adult is charged with fostering critical thinking skills. I mean, let's just be honest. So yes, Elizabeth, like the right level of thing to do for each staff member, but also that it's okay to do. Like, this is stuff that is going to help the kid engage academically. Yeah.
Just
Cool.
to piggyback off that one little bit is just kind of reflecting on some of the professional development in the past. But, you know, isn't it that the kids, you know, by the time they get up to secondary, the ones who struggle the most are the ones who are lacking in problem solving skills. And so if we can teach some of those problem solving skills earlier as just a part of basic education, just along with the critical thinking.
Good call, Elizabeth. As an example, we've rolled out a curriculum in our district that's cognitive theory based. It's called Trails to Wellness. It's an SEL curriculum. It's all CBT. And the argument is that this stuff is just good because it's good. One, you can't hurt a kid with CBT. You just can't. It's not a thing. You're not going to hurt a kid by helping them to identify automatic negative thinking and to adopt more rational, balanced, evidence-driven thinking. Just like that's just good because it's good. And mental health is good because it's good. We don't need arguments for why, like it's just good. It also happens to be good for all the other reasons that our stakeholders care about. So let's go through one more of these. I'd love to hear some new voices too. Come on, you're here. We have 43 minutes together. We kind of addressed the question in blue. How about this one that's in green? How would you secure buy-in from the mental health staff in your schools, the school counselors and school psychs and adjustment counselors and social workers? How would you secure buy-in from them to engage in evidence-based therapeutic practice? What would you say to them?
I don't have that problem here. If anything, they want more.
Good.
Yeah, they want more. Certainly one of the things that if I do talk with somebody who's a little bit resistant, I say, well, how's it working for you? You know, I mean.
Elizabeth, I love that. I love that. Who in here is in a mental health role in your school? Lauren, you are. Clancy, Claire, Lauren, okay. So let's be honest, and I'm going to be honest too. Has it ever been the case that you've met with a kid in excess of 30 times in a year? 30 sessions? Yeah, me too. Me too. It's just the way it goes. Cognitive behavioral therapy, soup to nuts, average amount of sessions, 12 to 20. So like, I do want to put on the table that if we're using really good evidence-based therapeutic practice, we're probably saving on time. We're probably being more effective, more efficient, getting kids what they need, not meeting 30 times, maybe still meeting more, but on average, bringing it down. Does that make sense?
John, can I ask if you are using, I think at least for me, some of my most frequent flyers are students on IEPs who have counseling services, which sometimes can be something that's really needed. And sometimes it's something that's overprescribed. And sometimes it's like, why can't we just be we're already reporting on these goals and objectives. If they meet them, why aren't they moving beyond this? There's just so many issues related to that. But if you are using these CBT practices, are the clinicians in your school district like writing IEPs differently? I'm just curious as to what that might look like.
Yeah, Lauren, you have kicked the hornet's nest. This is like a topic that it drives me up a wall. It makes me think I've got to ask the question, who here has seen this in an IEP? 1/30 counseling services forever, no end date, and we're measuring coping skills from 600 yards away while we're in our offices. Is it familiar to people? It's
yes.
How everyone writes those goals. How about instead we write that we are going to see a 15% reduction in symptom presentation on average during the first benchmark period relative to baseline. And we'll use a CBT approach to ensure that students get the skills and knowledge that they need to effectively address stressors. And the second benchmark is just a restatement of that, but it's a 20% reduction from baseline and 25. And instead of actually having a forever service situation, we're saying this service ends in 6 months. Oh, and by the way, I'm doing monthly pooled minutes instead of weekly so that I can fade my service. 90 minutes minimum per month so I can run 2 45-minute sessions, 4 30-minute sessions. I am actively changing what that service looks like without actually having to hold an amendment meeting. So Lauren, well played. Drives me nuts. We're writing goals differently. We're drafting services differently. It's not just for kids on IEPs. And I'll argue that mental health is for everybody. Why are we waiting for an IEP to provide services? Let's get ahead of it such that an IEP is not necessary. If you do me a favor, Lauren, or actually Ellie, if you don't mind taking a quick note, I will send a presentation out to all of you that that will outline this whole topic. I think it will, if that's of interest to people, but it's something we're definitely approaching differently. Okay. Keep going. We got 38 minutes. Your questions and engagement are throwing off timing in a way that I love. I have a bunch more slides, and you know what? Who cares if we get to all of them? We're having a good conversation. So the why of school mental health. If we're going to talk about sustaining school mental health, we need to defend why it's so critical. It's not the case that we can just simply, that everyone just believes it. Like, and to Paul's good point, you know, some people are, you know, have the argument that like, you just can't do it. It's not possible. Schools aren't designed for that. And I don't agree with that, obviously, but I think we have lots of good reasons why we should be doing this in schools. We have to align the benefits of school mental health implementation with those other outcomes, right? The outcomes that everyone holds near and dear. It's mental health first, then academics. That has to be the case. We also have to challenge this view of staff who are perhaps not positioned or ready or trained to do the work. I do think that the traditional view of school mental health centers around some misconceptions that we have to unpack. That community-based mental health is the answer. I hear that from some people, that we have to, that's the thing, refer and hope. I fill out the referral, I'm done my work. But, you know, how's that working? To Elizabeth's point, is that working? Because I hear 6 to 9 month waiting lists would be a dream right now. Now it's like 1 to 2 years. So we know that doesn't work, and that we have to build capacity within schools. I also hear this: when school mental health staff are not the primary service providers for students. That's simply not true for some kids. For some kids, we're it. For a lot of kids, we're it. And we're going to see some stats for that in a minute. Also, this idea that even if we wanted to address mental health in schools, school mental health staff are not trained to administer therapeutic services. Friends, that is just not true. It's just not true. And I'm going to show you why it's not true with a couple slides. I think in Massachusetts in particular, we've done ourselves a little bit of a disservice by, not disservice, I shouldn't say that, but we've complicated things. We've made things pretty messy with licensure and the many different roles that we have. Lauren's an adjustment counselor. Lauren, you have a role that is unique to Massachusetts. Like, that's not a thing that happens in any other state. And this idea of guidance counselor and school counselor and adjustment counselor and social worker and school psych, it's confusing. It's a lot. And there's a lot of role delineation that happens that doesn't make a whole lot of sense, especially when we consider the training programs that we're going to talk about in a couple minutes. So this part of the presentation, my friends, is where we challenge previously held beliefs about school-based mental health staff, or at least we're going to talk about them, because this traditional view of what guidance counselors do has persisted for quite some time while the role has changed and the training programs have changed. I'll show you in a couple minutes. We do have training, I talked about that. Let's just keep going. This is where things are going to get messy, friends, and we're going to start shouting at the screen. But here we go. These are the subject matter knowledge requirements for school counselors in the state of Massachusetts. This was updated in September of 2019. I would like to draw your attention to the items that are pointed at in red. Please take a minute to read. I did not draft these SMKs. This wasn't me. When an individual re-ups their licensure, they are saying, I know how to do this stuff. I'm good to go. I have sought out professional development such that I am ready to provide these kinds of things. Understanding of the diagnosis and treatment of learning and behavior disorders. Well, that sounds like evidence-based work right there. That doesn't sound like a light check-in. How about knowledge of strategies used for the prevention and treatment of substance abuse, physical and sexual abuse, the spectrum of mental illnesses and violence in pre-K through 12 students? I have to ask the question, is this how you or others typically perceive of the capacity of school counselors? Any thoughts here? Have you seen this before? BJ, you've seen this. I think we need to toe the line when it comes to what we ask our people to do. It's also the case that if we had more time, I would go through a ridiculous exercise with you where I would ask for you to report out on what you asked each of your staff members to do relative to these many different roles. And you would see a mess. In fact, if you keep with this training series, which I sincerely hope you will, you'll go through that mess in a few sessions. Yeah, Clancy, the school counselors in my building do not see themselves this way. It's fair. I know of other districts that would say the exact same thing. That being said, this remains true. These are the things that they're expected to do relative to the state standard and their license. So there's some disconnect that's happening. And I'm going to argue that that disconnect has a lot more to do with decisions that we've made and systems that we've perpetuated and roles that we have not checked and staffing models that we have not redesigned for years and years and years. Fair? Make sense? Let's keep going. These are the MASCA role-specific indicators, or at least one of them, for a school counselor. I'm not trying to pick on school counselors. I am one myself. I'm just pointing out that for sure, it is the case that in Massachusetts, we have conflated guidance counselor and school counselor to a point where we don't actually recognize what school counselors can do. Seeks out and implements evidence-based counseling theories and techniques to deliver short-term counseling with, if we look up the definition of short-term counseling, 3 to 6 months, and it can go longer. What is evidence-based counseling except something that ends in the dreaded T word? You know what I'm talking about, therapy. People get so bent out of shape when we use that word, but I don't know what else to call cognitive behavioral therapy. It's in the name. DBT, SFBT, all these things, that's what evidence-based counseling constitutes. So if the Massachusetts School Counselors Association drafted this such that school counselors should be doing this stuff, then how come they're not doing this stuff categorically? Because we haven't told them to do that. We haven't leveraged them effectively. We haven't re-upped our staffing models. Fair? Make sense? Why are we talking about this? Because the why of school mental health requires us to say schools actually can do this stuff. It's not only important, but we have people to do it. How about this one? This is the Salem State University degree requirements for school counselor or adjustment counselor. Friends, it is the same training program. It's choose your own adventure after you go through the training program and pick the license you want to apply for. There's no difference between the courses. Why do we ultimately treat school counselors and adjustment counselors wildly differently when they have the same training? That's weird. Fitchburg State, what are the differences between programs that prepare school counselors and LMHCs? I've got to imagine that there is a world of difference between a training program that's readying up a school counselor and someone who is an LMHC. Would you agree? Probably true. Yet here we are. This is a very messy crosswalk, but what it shows is that there is not much difference at all between an LMHC training program and a school counseling training program. Not much. Assumption, UMass Boston, Merrimack, it's all the same thing. So, you know, why do I offer this? I think it's really, really important for us to recognize how we are perhaps not leveraging our school-based mental health staff as effectively as we could be. If we're going to say that school mental health is important and we should be doing it, then we also need to say, and we have the capacity to do it. And right now, if we don't leverage all these people, we don't have the capacity to do it. Does this make sense? Gina, no worries. So glad you were here. Check out the recording for the rest. Yeah, incredible. We have LICSW and LMHC that provide therapy in outpatient settings, fee for service as a part-time job, yet they still think that referrals to outpatient is necessary. I'm guessing while they're on the job in schools is what you're referencing. It's very strange, friends. I guess what I would ask is this. One, I hope that this has been a challenge to your current thinking around who you can leverage for this work. I also know that it is the case that changing hearts and minds is very difficult, and changing a staffing model overnight is difficult. So let's know that the onus is on us to change the system. Let's know that no one else is coming to the table in your district to review and change the staffing model except the people at the table who do that. It's a local decision, and the training exists. We're just not leveraging it. I've got this theory that I have to share with you. We've got these beautiful master's level training programs, and they're churning out master's level clinicians, school counselors, school psychs, adjustment counselors, social workers. What happens at the end of that beautiful training experience? Sometimes, a lot of times, a pretty terrible practical placement, where the process of unlearning begins and we start to adopt and revert back to the system that has persisted over time. Then we get hired in a system that further reinforces that we should abandon what we just learned. And what happens then? Well, we're back at square one. So it's one of the reasons why clinical leadership is so important, to keep the eye on the prize front and center, to advance professional development for the people for whom we'll be tasked with providing these services. There's a whole different training series on mental health leadership that we offer, and I would ask that you check that out. But in the absence of clinical leadership and clinical evaluation and supervision, then we have a lot of people that are unfortunately left without a direction, and left without good PD, and left without good feedback, and left without appropriate leveraging. We're using these people ineffectively. So food for thought. I don't want to knock community-based mental health at all. I love our community-based mental health partners, but again, they can't be the solution. They're part of the solution. Do these things ring true to you in terms of barriers to community mental health services? Come off mute and share if you have had to deal with this in terms of making referrals to community mental health. What do we got?
I can talk a little bit. We're in a rural area, and pre-pandemic, we had a lot of trouble finding services for kids. And now it is just, it's wild. People are getting text to talk about the school adjustment counselors. People are getting text messages from all over just saying, hey, when you decide to start up that private practice, I've got 30 clients for you when you're ready. And it's just, it's tough.
Yeah. Good call, Lauren. I appreciate that rural perspective too, because it's a different kind of need for sure. What about others?
All of the above, you know.
Yeah.
What else is there to say? It's true, you know, and I think that we are the forefront of you know, we see the kids, they're a captive audience to school counselors, you know, they're right there.
Yeah. Good
With
call.
us.
Good call. Something as simple as transportation can be the difference between a kid getting services and not. That's it. How about asking an adolescent to do anything not fun after school? Not going to happen, right? That's an immediate no-go situation. So just, we got to bear in mind these things that pose pretty significant barriers for kids. And let's make it worse and talk about show rate. So the national average show rate for community-based mental health, I will draw your attention to the chart on the right. What you see there is that 28% of kids never make it to their first appointment. And after about 3 months, about 9% have persisted in services to the point where they get minimal care to address the needs that they, we know that like about 3 to 6 months is when we start to see some gains made. This is miserable. This isn't something that works. Refer and hope doesn't work.
From the other perspective, because I am one of those LICSWs that work outpatient, because of all the waiting lists and the length of it, there's no like incentive to track them when they don't show up, right?
Right,
Like
right.
they just disappear. And, you know, you have, you know, clinic directors that are saying, if you have, you know, 2 no-shows, just, you know, terminate them and let's go to the list. It's very revolving door out
Yeah.
there.
Good call. Really good call. I appreciate that perspective a lot. I got to imagine that some of this stuff is contributing to that lack of show rate. But 9% getting minimal care, no good. How about this? Let's imagine we've got 100 kids who need services, okay? Follow me with the math, my friends. We know that nationally 50% will never be identified or enroll in services. So it's sad to begin with, right? Half the kids that need help aren't going to get it. We also know that 75% of kids that get services for mental health get it where? In schools, which is weird that schools are not an approved site for clinical supervision, but that's a topic for another day. So we're saying basically that of that, the 50 kids that are going to get help, 75% of them are going to get help in schools, and 25% of the 50 get their help in community-based mental health settings. Wonderful. They made it through those barriers to get to community-based mental health. That's about 12 kids, because I'm not going to cut a kid in half. Okay. And we've got 12 kids now who are going to get services based on in a community-based setting, but let's refer back to show rate. Great. About 4% will receive about 6 or more sessions in an outpatient setting when all is said and done. We can't be okay with this. This is miserable. And when we boil down the numbers, schools are already the primary source of mental health services for students. To Paul's point, they're with us all day long. It's where they go and who they know. I talked about the disadvantages of not providing mental health services. Well, here are all the good things that we get when we embed mental health in schools. That 9-month waiting list is erased a lot of times, or it's reduced significantly. We generalize the treatment to the child's context. We make it natural, normal. They know us already. We're just making it another part of their day. It's a less threatening environment, quite frankly, because it's a place that they're used to and know, and you might be meeting with your counselor for something else anyway. And now we're going to pick you up for this other service. Okay, offered in the chat. We do have practicum placements for MSWs. Many universities are seeking school placements, but not proper supervision available. We've developed a program to provide the clinical supervision. I applaud you for that, because there's a dearth of clinical leadership in this state, and that is contributing to a failure to leverage our school-based people effectively. Monica says, thoughts on schools facilitating community virtual therapy during the school day? It's been a stressor in my building trying to get kids on their sessions. I guess, Monica, like I love the idea of leveraging telehealth, not if we're going to ultimately say, hey, you school-based mental health staff member, make sure that you are supervising the kid in the room while they're getting the therapy session. It's a wash. What's the point? We need better model than that. But I'd be cool with augmenting the available services with telehealth for sure. I think it's great. So lots of reasons why there is, yeah, it can be tough. It can be tough. And a lot of, I know that, you know, kids will report that it's not exactly the same kind of experience too. So it's worth considering that, definitely. But lots of advantages. These advantages run counter to all those disadvantages I talked about previously. We're also providing greater access to care. At the end of the day, it's about access to care. It's cost effective, greater potential to impact the learning environment. We're also offering services in the context of where a lot of the most stressful pieces for our kids are happening. You know, social conflict, academic performance impacting anxiety and depression, all that stuff. So, you know, a little more of the why. We are uniquely positioned. It's direct, consistent contact with students, access to services on an ongoing basis. It's a team-based approach as well in a natural setting. If we don't provide these services and supports, kids don't get the gains we want for them and that they deserve. And we're also not preparing students for life after high school if we don't directly address students' mental health concerns. One of the things I wanted to say earlier, and I kind of forgot, was I think schools need to adopt different metrics for what's important and for what they are readying up students to do. I know that we care an awful lot about life after high school, but we're not doing our kids a great service if we don't prepare them for life after high school, inclusive of their mental well-being and their resiliency. I think that when we only put our eggs in the post-secondary matriculation basket and we fail to recognize that many of those students will ultimately not persist to a second year if they don't get mental health services and supports, that's a problem. We have to recognize and reflect on that. We do our kids no good if we just get them over the finish line and don't provide the care they need. We don't need to go over this, do we? My God, you get it. You understand. It's all the things. It's the opposite of all those problems. Healthcare, incarceration, substance abuse, behavioral concerns, attendance crisis, all this stuff is mediated by mental health services and supports. So if we bring it all together, we do know that mental health problems are pervasive, for sure, especially for school-age children. They result in a litany of problems that impact schools and society. Okay. Community-based mental health, love them, part of the solution, not the solution. We have a role to play. It's essential. No other institution is going to come to the table to enact prevention and proactive preventive services. Students don't make academic progress when their mental health needs go unmet. There's a heavy cost associated with inaction. If we don't do this now, then we don't get the mental health thing, and we also don't get the academic thing. And yes, uniquely positioned. We are. We've got thousands of mental health staff dispatched across schools who are already positioned to provide services. The big question I would offer to you today is, how effectively are you leveraging those staff members? How effectively are you supporting them with good professional development? How effectively are you providing the clinical supervision and evaluation they need to grow as professionals? And if any of those things are not in place, then how are we supposed to advance this work? Okay, we've got 15 minutes left. I'm going to pop you in breakout groups. And what I would like for you to do is to take a look at this document, which is going to be a central document and framework that we use for this training series. It calls out some guiding principles and a checklist of essential features of a comprehensive school mental health system. I designed this for a group of superintendents that I was working with through EAB, which is out of DC. And the idea is this: here are the 5 guiding principles of a comprehensive school mental health system, stuff that we need to account for and embrace if we're going to get this work off the ground. And then on page 2 is the, at the time it was the return to school checklist, but it has become really like a call out to leadership about the kinds of things. Paul, no worries. Thank you so much for being here. I appreciate it. The kinds of things that you would want to see in a comprehensive school mental health system. So what I'd like for you to do is, in your small groups, I'm going to assign each of you one of the guiding principles. Or how about this? Like, you pick a guiding principle that resonates with your group. Okay, one of the 5. Good. And I'd like for you to talk about it. What are some examples of how your group has championed that guiding principle? And how could you communicate the importance of this guiding principle better? Let's stop with that. That's enough for the remaining time. I'm going to give you 10 minutes. I'll give you 8 minutes. 8 minutes, and then we'll have 5 minutes to kind of wrap up. Cool with people? We know our marching orders. We're good? No problem, Monica. All right, I'm going to set these breakout rooms up. We need, I don't know, let's do 4 breakout rooms. I'm going to open them up now. You have the document? Thumbs up? Yes?
No.
No, it's in the chat. Up in the
Okay.
chat. There we go. So I'm going to open these up. I'm going to pop around, but pick a guiding principle. How are you doing with that guiding principle? How could you communicate the importance of that better? Cool? All right. 5 minutes. I mean, sorry, 7 minutes. Open up the rooms. It was unfortunate. So, friends, we got 4 minutes left. I'd love to hear snippet of your conversation. Are these guiding principles resonating with you? Do you feel like they're alive and well in your district? And if not, what can you do better? What we got?
They are helpful and not at all alive and well.
Sorry. That makes sense. Makes sense. Which one do you think is least in place in your district? Quick call out. What do you think?
The supervision, definitely not at all.
There you go, Lauren. I had a great opportunity to chat with Lauren about her situation. And Lauren, you okay if I share a little bit? Okay. Lauren offered that, like, I'm a little bit nervous about coming to the table with a case that I don't know how to address because I feel like that's going to make it appear as though I don't know what I'm doing. What I offered to Lauren is, as a clinical supervisor, I'm actually going to give you lots of credit for coming to the table. It's a +1 in your evaluation column, as opposed to a knock on your performance because you knew when to get case consultancy. Fantastic. You're abiding by your ethical code. Well done, Lauren. But without clinical supervisors who know about stuff like that, it might not go that way. Also, please know I'm not knocking anyone who's being charged with providing supervision and evaluation to mental health staff when they have no mental health background. I feel like that's unfair to start with. We're asking people to do so. I would be a pretty terrible supervisor of mathematics. I love math. I don't know that I've got the pedagogical, I guess, wherewithal to be able to do that well. That wouldn't be fair. Okay. Any last thoughts on these guiding principles? You're going to use them. You're going to gun for them. We like them. Okay. Also, this stuff, important stuff, this is what constitutes a comprehensive school mental health system in a lot of ways. Go through the process of, like, see if you can check off some of these boxes and see what you can. And then use the SHAPE system, which is an even better tool, and get an action plan in place. My friends, we got all kinds of sessions coming up that's going to unpack a lot of that checklist with sessions that focus on specific aspects of it. This is where you can get some info on the Thriving Minds Initiative. This is where you can sign up for the Massachusetts School Mental Health Consortium. All are welcome, everything's free. But what questions do you have, my friends? What do we got? And Ellie, I don't know if we have an evaluation for this this session, but if we do, that'd be cool to drop in the chat. Final thoughts, my friends. Aaron, no worries. Glad you were here. Okay. I'm going to stick around for the next minute or so. I'm so thankful that you're here, that you're leaning into this work, that you're doing the hard work and asking hard questions, challenging previously held beliefs so we can get to better systems for our kids. So again, thank you for being here. I'll stick around. I hope to see you at the next session. Take care, my friends.